Officer, the California Healthcare Foundation, and the new director of the California Improvement Network. It's a pleasure to welcome you to this two-part introduction to transgender patient care. Our first webinar, Understanding Transgender Identities and the Unique Care Needs of Transgender People, was held on May 4th. A recording is available on the CIN website in case you missed it or you'd like to share it with your colleagues. Today we're going to continue the conversation with how to improve care and the care experience for transgender people. Our two presenters will cover the basics of clinical care for transgender patients and how to provide equitable and culturally sensitive care experience. A few housekeeping items. During the webinar, all lines will be on mute. However, we encourage you to use the question chat function in the webinar software. You should see that to the right-hand side of your screen to ask questions as we go. We'll have time after each speaker and again at the end of the session to go through questions that have been submitted. The session is being recorded and it will be available along with the slide decks on the CIN website within a week. Also, both Lyon-Martin Health Services and the UCSF Center for Excellence for Transgender Health offer a wide range of resources to help healthcare providers and staff learn more about evidence-based care and improving the patient experience. We'll provide direct links to those resources, those websites, at the end of our session today. And now for introductions. Our first presenter, J.M. Jaffe, is the Trans Health Manager at Lyon-Martin Health Services, a primary care clinic in San Francisco that serves transgender people regardless of their ability to pay. There, J.M. manages Project Health, a program that aims to improve access to transgender health through education, advocacy, and leadership. JM also manages TransLine, an e-consultation service that connects providers nationwide to experts in transgender care. JM also works to ensure insurance coverage of medically necessary care for transgender people. Notably, JM played a major role in advocating for Medi-Cal and commercial insurers to cover gender-affirming surgeries and for the state of California to begin enforcing the Insurance Gender Non-Discrimination Act. JM graduated from Wesleyan University and studied biology, feminist studies, and pre-med. Our second presenter will be Maddie Deutsch. Dr. Deutsch is an assistant clinical professor in the Department of Family and Community Medicine at UCSF. She is the Director of Clinical Services at the UCSF Center of Excellence for Transgender Health, where she conducts research and provides support to agencies developing and implementing transgender care programs. Dr. Deutsch is also the director of the UCSF Transgender Care Navigation Program. She's a recognized expert, has written numerous peer-reviewed articles, and lectured internationally on a range of transgender health and medicine topics. She serves as an associate editor for the journal LGBT Health and is on the editorial board for the journal Transgender Health. She's currently overseeing the development of a telemedicine program that will allow patients to be seen by remote computer connection, and is also leading efforts at UCSF Medical Center to implement best practices for transgender patients, such as the use of preferred name and pronouns. Let's begin. Jan, the floor is yours.
All right. Well, thank you so much. So this is a follow-up from a previous talk, part 2, and so I'm not going to be going over any basics of the transgender experience. What I'm going to be focusing on today is how to create a gender-affirming clinic environment, and specifically this is directed towards primary care, but it can definitely be applied to any practice, so take what you will from this. All right, next slide. So again, my name is J.M. Jaffe. I'm the Trans Health Manager at Lyon-Martin Health Services, and we are a primary care clinic in San Francisco. located on Market Street that serves cisgender women, lesbians, and transgender and gender nonconforming people, regardless of their ability to pay. Next slide, please. And I'm also the manager of a program of Lyon-Martin called Project Health, which stands for Harnessing Education, Advocacy, and Leadership for Transgender Health. Our aim is to improve access to transgender health care through education, advocacy, and leadership. What we found was that people were coming to Lyon-Martin from all over the state, all over the country, because there just wasn't enough access to transgender competent care. And so we formed Project Health as an education program to try to improve that access to care. So we do trainings usually for medical providers and clinics, or providers to be, so students, medical students, and any other medically based facility, so insurance companies, anything that's really relevant. We also have a clinical rotation in transgender medicine at Lyon-Martin for future or current providers. And we established the Trans Line, which is the e-consultation service. So it's really a readily accessible online system. So you can ask patient-specific questions and get connected to experts in transgender care. That's currently staffed by providers at Lyon-Martin, providers at Bay State Health in Springfield, Mazzoni Center in Philadelphia, and Fenway Health in Boston. We also do maintain a presence in policy change efforts on a local, state, and national level. And they also manage all of the surgery referrals at Lyon-Martin to ensure that people's surgeries are getting covered and are deemed medically necessary by the insurance company. All right, next slide. So just a quick overview. Transgender people use any number of ways to express their gender identities. And everyone's different, so some people will use a couple of things from this list. Some people will use all of the things from this list. Others will use none of them. And what I really want to get across here is that there's no linear start and end path for a gender transition. It's really specific to the person, what their transition goals are, and what they have access to as well. So some things that people may or may not use include changing their name, changing their pronouns, coming out to friends, family, or their community, changing the way they dress, their clothing, their hair, their makeup, using different facilities like bathrooms or dressing rooms, changing identity documents, so whether that be just their names or their name and their gender markers on their license or passport, birth certificate, social security card. There's also a number of different compression or prosthetic devices that people can use without having access to surgery to alter their bodily appearance. People also may speak in a different vocal pitch. Many people see body modifications as essential to their gender presentation, so whether that be tattoos or piercings. And then as far as medical interventions, there's of course hormone therapy like estrogen or spironolactone or testosterone. And there's also many different options for surgical interventions as well. Next slide, please. So many clinics ask me, how can I help? How can I make my clinic really responsive to people's gender identifications? How can we change something that's so set in stone to be so flexible with how someone may identify? And so what I'm going to talk about in this talk is how we can use a medical system that isn't really made for trans people to accommodate them and to respect them. Next slide, please. So the biggest thing that we can do as providers is to reflect trans people, to show them that we understand them, to show them that we have their community in mind, to show them that we have their community included in our staff, that we really reflect back their identifications and their presentations to show respect and to show that they're important to us. So the first thing that I always tell people to consider is the organization's name. And one thing that always comes up is the term women's health. And women's health, you know, I'm all about women's health. I'm all about, you know, the women's health movement, that whole feminist empowerment initiatives. Like, the history is so strong. The importance of that is just really, really the groundwork for a lot of radical movements for healthcare. And the issue with it, though, is that it doesn't really encapsulate what we're really talking about. So when we think about women's health, we think about you know, pregnancy resources, abortion, reproductive health, like anything that has to do with specific organs in the body, right? And yet this is a limiting way of talking about it because, you know, we have a lot of trans people who identify as women, who are women, and yet do not have the organs that this particular model isn't really talking about. And the other issue is that many people with these organs don't identify as women. So trans men who still have cervixes still need pap smears. Trans men who can get pregnant still need pregnancy resources, still need abortion and family planning resources. And so for many trans people, this framework of calling it women's health can be a deterrent to seeking care there. Like, oh, this place doesn't actually understand my gender identity, so I'm not going to go there. Next slide, please. The other thing is that a website and the advertising presence is really important for queer and trans people to really know that this place is going to respect you. It's good to advertise that you understand, that you have been trained in how to be LGBT friendly, because the standard is that you go to any old doctor's office that you're not going to be understood. And so going to someone's website and seeing something like, oh, this is a safe zone, or, oh, we do trans health, can be a major encouragement factor for people to actually come to your clinic. Next slide. So the next thing is, once you actually have the trans person in your clinic and walking through your waiting room, it may be a good idea to invest in some inclusive posters showing that, you know, you're thinking about trans health, that you know that PAPs matter for trans men, that you know that that breast exams matter for trans women, and you know that can go a long way for making a trans person feel comfortable in your clinic. The next thing I tell people is to abandon pink and blue color schemes. Any kind of gendered color scheme involves pink and blue. Again, we're just trying to get away from gender norms here. And even if this may feel empowering for some trans people, it doesn't for all trans people. In fact, I would say on the most part, it feels kind of like you're boxing people in to gender roles. And that's the exact thing that trans people, for the most part, are trying to get away from. Okay, so this is the most important thing. When you're thinking about creating a inclusive clinic, trans people want to see themselves reflected in your staff. And not only will this go a long way as far as making a trans person feel comfortable in your clinic, but also the trans people that you hire will give you their opinions as well as far as making your clinic more inviting, or they'll have ideas about how to reach out to specific communities, and they're really invaluable workers. So this recent campaign, Hire Trans, has been started by the Trans Employment Program, and you can actually partner with the Trans Employment Program to get trans employees to apply to your organization. So it's a really cool program. And lastly, as far as HR, sorry, go back. As far as HR is concerned, if you're going to hire trans people, a big thing you should make sure is to ensure that your insurance options do cover hormones and surgery, and that you have a non-discrimination policy in place to protect your employees. All right, go ahead. So once your trans patient has entered the waiting room, has felt comfortable there, you often give them some paperwork to fill out, some new patient paperwork, their history. And so the first thing that you're always asked is what's your name and what's your sex assigned at birth. And so a big thing to think about is how can you accommodate the diversity in sexes that exist, like intersex people, and the diversity of gender identity. So this is our demographic form that we give to our clients so that we know what their gender identity is, what their biology is, and what their pronoun preference is, so that you can actually respect them. We have to make a couple different workarounds with our electronic medical record to make sure that we do respect people's names and pronouns at all times. And so you'll have to work with your organization to really, on a universal level, make sure that that is documented in a consistent place and everyone knows where to look for that information so that you can constantly be respecting your client. HRSA recently released requirements that require organizations to collect sexual orientation and gender identity data. So it's shortened as SOGI data. And so this information not only is important to respect your client, but also is a new requirement coming down from HRSA this year. So once you have that information, since you've asked them what their name and pronoun is, it's even more important than to respect that name and pronoun all the time on every document, even if the person's not around, even if you've never heard of that pronoun before, even if they haven't medically transitioned and don't necessarily look like the gender that they identify as, even if it makes you feel uncomfortable. And, you know, I think the biggest advice I can give anyone here is that if you're ever unsure, if you just need to double check, you can always privately and politely ask them what their pronoun preference is again. There's no hurt in asking again what they prefer. And usually most trans people will never find that like offensive. It's actually a sign of respect to ask, what pronoun do you prefer? The other thing that we do is we have been using they and them as a gender-neutral pronoun until you know what to use. So, and that's across the board for everyone. So at Lyon-Martin, we just are constantly talking about people with they and them pronouns unless we specifically know what pronouns they prefer. For trans staff, a really good thing to do is to use chosen names and pronouns on all your email, all the emails that are assigned to them, in the email signature. So in all of our email signatures, we have our names and then preferred pronoun, they, them, or whatever it may be. We also have our preferred names and pronouns on our name tags, and anything HR related, unless it specifically needs to be the same name as that's on your ID for like your paycheck or insurance reasons. And we do this for everyone across the board, not just trans people. So, you know, even cisgender people may have other names they prefer, and we always just try to respect everyone at the same level. So there's many different pronouns that people may choose to use, and so it's really good to educate yourself about different pronouns that people may utilize and just practice, like in your spare time, just practice. The other thing that we usually recommend is to abandon any kind of titles, so no Mr., Ms., or Mrs., and no reference to sir or ma'am, or miss. Any kind of gendered language like that, we just drop. We also have been using gender-neutral restrooms across the board. So basically, anyone can use any restroom they feel most comfortable in. And actually, recently, this past week, California recently passed a law requiring all single-stall bathrooms be designated as gender-neutral. So any single-stall bathroom in any public place should be open to anyone regardless of their gender identity. The reason this is so important is that, you know, recently there's been a lot of backlash to the national awareness of trans people's existence. I'm sure you've heard of North Carolina's famous laws that have been widely disputed recently. And, you know, it's a safety issue for trans people. So in North Carolina, they're saying you have to use a bathroom that corresponds to the sex that you were assigned at birth. And yet, you know, when trans people are doing this, they're putting their safety greatly at risk. This is pictures of people taking selfies in the bathrooms that correspond with the sex that they were assigned at birth, and you know, how ridiculous it looks essentially, and how humiliating it can be for a trans person, and a safety risk. So this is a big, changing identity documents is a big way for mental health staff and social workers to get involved in trans care. Changing identity documents can be a very arduous process, and as much support as can be given is great for trans clients. So in order to change your identity documents, you need to obtain a court order, which requires lots of paperwork. And actually, in order to change any gender marker on your documents, you need to obtain a physician's letter. And then after you get your court order, there's more paperwork and sometimes more forms for the physician to sign. And so, you know, it's something that both social workers and physicians can be super helpful in guiding people through. The Transgender Law Center created a pretty exhaustive document on changing documents in California called ID Please, and it's freely available PDF as PDF online, so feel free to take a look at it if you're interested in more information there. There's no gender-neutral option, so it's either male or female in the US, but Australia and India do have an X option. So I think a lot of people are hoping that someday there will be no gender you know, option on there, but currently that's the state. So lastly, for mental health services, I mean, therapy is extremely useful. It can be a really stressful process to come out. And studies show that the more accepting your family and community are of your coming out process, the more likelihood that you are to survive and think that you will, you know, have a happy life later on. So that's a very important support module as well, not only for individual therapy, but also family therapy. As I mentioned prior, prosthetic and compression devices are really useful for people to modify their bodies without actually undergoing surgery. And so at Lyon-Martin, we have created a binder exchange program. So people use chest binders to bind their chest and make it look more flat. And you can use this same model for any type of compression or prosthetic device to trade clean items between people. So when we think about medical transition, I think one of the biggest things or concepts to wrap your head around when you're trying to create a welcoming environment for a trans person is to think about their choices with their body as an act of self-determination. Not to really question it, and definitely help them explore their gender identification, but not to question it. And to realize that if you decide not to give this person hormone therapy or a surgery, that you could be putting their life at risk. There is a big danger of black market hormones. So if people, are denied hormone therapy and then go and find hormones on the street or on the internet, there's a big risk for liver toxicity and incorrect dosing. And then also, suicide attempts in the transgender community are 41%, compared to 1.6% of the general population. So that's also a big consideration. When people are using hormone therapy, they are using needles, often using needles for intramuscular or subcutaneous injections. So using a harm reduction model with needle use is really important to help people understand safe injection technique and provide training, provide sharps containers, lists of local needle exchange sites. And we also have an informed consent model for hormone therapy, so we don't ask someone to get a therapy letter or anything like that to undergo hormone therapy. As long as they're medically stable, we do just give them a informed consent handout to sign. Sorry, my computer is doing something weird.
JM, you should see the surgery coordination slide up on the screen right now.
Okay. Sorry. 1 second. Okay, so as far as surgery coordination, a couple things to do is to familiarize yourself with the local surgeons available, any kind of voice training or hair removal resources, and what insurances they take, as well as just generally familiarizing yourself with surgical options for gender transition, because people will be asking you what's available and what's covered by their insurance. And then once they do have surgery dates scheduled, helping them coordinate pre-op planning to ensure best outcomes, and familiarizing yourself with post-op complications and needs that may come up. Next slide. There's also a big role for medical providers and mental health providers to provide letters of medical necessity to ensure that insurance companies will cover surgeries. And they usually go by what's called WPATH Standards of Care, World Professional Associations for Transgender Health Standards for Care. And so that means that they generally will require one medical letter of support, and then if they're getting a surgery above the waist, one mental health letter as well. If they're getting a surgery below the waist, they do require 2 mental health letters from 2 different mental health providers. So the surgeon is going to require this, and any insurance company will also require this. There's also oftentimes a role for navigating appeals and any kind of denials from insurance companies. Many insurance companies don't really know the laws in California and don't know that they are required to cover medically necessary care. And so oftentimes you will get a denial, erroneous denial from insurance companies. And so it's important to know how you can advocate for your clients to appeal that process and get their surgeries covered. The Department of Managed Healthcare can be very, very useful in this regard. So on the state level in California, there is a law called the Insurance Gender Non-Discrimination Act. It was passed in 2005. And the Department of Managed Healthcare has clarified that this law does indeed mean that any insurance company in California cannot have a blanket exclusion on transgender care. They need to have a policy that provides a path to care. So whether that be having certain requirements in order to be able to access care, or just having any kind of specific surgeons contracted, that they have to be able to have some kind of pathway to surgery. On a federal level, the Affordable Care Act has a section in it, it's called Section 1557, that also prohibits gender discrimination. And this has recently been interpreted to mean that any covered California or ACA insurance plan as well cannot prohibit blanket exclusions. So this is, a very recent development that this has been clarified on a federal level, that discrimination in healthcare regarding gender identity is illegal. So coming to a close, talking about bedside manner. When we talk about bedside manner in the preventative care arena, we always test based on what organs are present, and we don't assume what organs are present. So we always ask, what's your surgical history, what sex were you assigned at birth, to know what to test for and what people are at risk for. We also use the same language that the patient uses for their bodies. So some people may have dysphoria around using certain language that is accepted in the medical community for their bodies. And so you may want to ask someone, what would you like me to call this part in order for me to do this particular test? We also don't assume what kinds of sex people are having based on their gender or biology. We always ask, what parts are going into what parts when you're having sex. So you really have a good idea of what their risk is and what kind of sex acts they're engaging in. We try not to be invasive. So only asking relevant questions is really important for a transgender person to feel respected. I remember one time I was in the ER for a throat infection, and the nurse just started asking me all these detailed questions about my gender transition, and it was just really inappropriate, and it's not something I wanted to be talking about at that time. I was sick and needed care, and it can be a big turn-off for any kind of trans person trying to access care. The last thing I listed here is review any kind of educational materials for gendered language. And this, again, kind of comes back to the women's health issue. If we're talking about men's health and women's health, it really doesn't make sense for trans people. If you have breast cancer and you go to look for educational materials on breast cancer and you see only cisgender women presented on there, and it's pink, and it's really hard for a trans guy, trans man, to feel like this educational materials, these educational materials are applicable to him when everything is pink and doesn't make sense for his experience. And the same is true for example, prostate cancer with transgender women. They're not going to go to the men's health section if they are a transgender woman. It's not going to feel safe for them, and it's not going to feel applicable. So integration is really, really important. So when I do these trainings, I really try to educate everyone, not just providers, but their support team, medical assistants and RNs, the social workers, the therapists, psychiatrists, support staff, billers, the HR department, really anyone that's going to be interacting with the client is going to need to know how to respect this person. And I just added some resources for protocols and also any kind of questions around how to implement the SOGI data requirements, sexual orientation and gender identity requirements. There's a lot of great information on the Fenway National LGBT Education Center's website. And if you have any medical questions, the Transline is always available to use to have expert consultations. Thank you so much.
Thank you. All right, we've had 2 questions come in. I think we'll take one now and then hold one for later in the hour. The first one comes in from Mimi, and I'm guessing she's at a healthcare delivery organization that has women's health in the title because she's asking for suggestions. Should it be no gender at all? We'd like suggestions on the changes you propose. Naming of clinics and healthcare organizations.
Mm-hmm. So that's a great question. I think one thing to consider is what services are you purporting to provide? And I think that should really determine what the name is, or if there's like a person that you want to name it after that was significant to the women's movement, or the other option is calling it like a feminist health center. I think there are other, or like a gender clinic. It's really about, gender oppression, right, and patriarchy, and how to carve out a safe space for these people, right? And so I think if you're really going to accommodate trans people, thinking more broadly about gender oppression in that way may be helpful.
All good ideas. Thank you. And again, for audience members, if you have a question, please feel free to use the chat Q&A function there on the lower right-hand corner. Send that in, and we'll circle back to questions at the end of the hour. And next, Maddie.
Great. Thank you, and thank you, JM, for your contributions. So I will jump right in here. Is it possible to go back to the header slide? Great. So I am at UCSF, and that slide tells you who I am. I just wanted to very briefly talk about something that was mentioned in the prior section about location of services and where a service might be located. And as you see, I practice in a women's health setting. And the reality is that all transgender care is not going to happen at a transgender-oriented clinic. And most transgender care that is probably happening now and that will be happening in the future is going to happen in an unselected population of primary care clinics around the country once we step outside of the bubbles of the major cities. And so I think it's important to keep in mind a lot of the ways that we can make clinics welcoming and appropriate for transgender people, and at the same time we should not let the perfect be the enemy of the good and say, well, I work in a women's health center and we're not going to be able to rename our entire organization or our entire clinic, so I guess we can't do transgender care. And I've been involved in capacity building at 6 or 7 institutions that were not LGBT health centers and helping them develop transgender care programs. And they've all been successful. And so there are a number of ways to integrate appropriate transgender care into a larger system if that organization is not going to be able to rebrand itself for its focus on transgender people. And you know, at Women's Health Primary Care at UCSF, we have our own transgender care website, and we do discuss in detail why transgender care is co-located at a women's health center. Women's health providers are also familiar in the care of people who have penises, and we have about 10% of our patient population are non-transgender men whose friends, wives, relatives liked their care, and they chose to make us their primary care home as well. So I just wanted to provide a counter perspective, since I suspect there may be many on the call, on the webinar, who are at larger organizations where eliminating women's health or other content from the name may not be readily possible. So we can go on to the next slide. And I'm going to kind of give a whirlwind discussion of a variety of specific treatments and procedures that transgender people may seek. So transgender people, in the course of seeking affirmation of their gender by helping to align their body in a way that is congruent with their internal felt gender identity, may seek any combination of hormone therapy, surgery, other procedures such as hair removal, speech modification. We can go to the next slide. Other non-medical interventions, which were touched on by JM's talk, chest binding, packing to use a penile prosthesis, tucking, which is displacing testicles into the inguinal canal to allow a female genital contour when viewed externally, and some scalp hair procedures. And I think what I would want to say about all of these things is to emphasize that not all transgender people seek all of these. Some transgender people seek some of them. There is no one order in which to seek these procedures. And then there are some transgender or gender non-binary people who don't seek any of these procedures and simply affirm their gender through their own lived existence or social interactions or any other way that they feel is appropriate. Next slide, please. So some common surgeries that are pursued by people on the transmasculine spectrum. So by transmasculine, I mean people who have some kind of gender identity that differs from the birth sex which they were assigned of female. So they may identify as men, they may identify as something else, but they are people who do not identify as women, even though they were assigned as female on their original birth certificate. And so mastectomy, which is colloquially referred to as top surgery, and then hysterectomy we're familiar with. Phalloplasty is the creation of a penis, and then there's a procedure called metoidioplasty, which involves some reconstruction of the clitoris, which grows with testosterone therapy, and there are different procedures that can be done to help that more approximate the appearance of a phallus. For a transfeminine spectrum people who are familiar with breast augmentation, vaginoplasty is a procedure where the penile skin is removed, and the innards of the penis, the erectile tissue, is removed, and the penis is inverted, and then is created, a vagina is created out of inverted penile skin. Some transgender people may seek only orchiectomy, which is removal of the testicles, and then there are a number of other different cosmetic, quote-unquote cosmetic procedures that any transgender person may pursue. I put cosmetic in quotes because they're not actually cosmetic in the colloquial sense where you might say, oh, you know, over the Thanksgiving holiday, my sister-in-law had some cosmetic surgery done. These are procedures that bring about cosmetic changes, but they're not really cosmetic surgery because in the context of gender affirmation, these procedures really would be considered medically necessary. Next slide, please. So why do we offer gender affirming care? Well, there's been a number of studies that have been conducted, and there are more that are coming out that show improvements in a range of measures of anxiety, depression, social functioning, and quality of life. and both from hormone therapy as well as from surgery. There have been some study, there was one study that looked at the two of them combined. Next slide, please. The regret rates relating to these surgeries, once you've undergone the entire process, the WPATH process that JM referred to, regret rate is very rare. If you think about regret rate for other things in this world, 1% or less regret rate for anything is somewhat remarkable. And most of the cases that have been reported of regret have involved people who've undergone surgical complications, who've experienced surgical complications. And so they maybe regret having vaginoplasty because now they have chronic urinary problems, which is a bigger discussion that we don't have time to get into here, but these are major and invasive surgeries, and it's important that the informed consent process when preparing a patient for these procedures not be just shoving a consent form in front of them, but actually making sure that they understand. We also think that when we bundle hormones or other gender-affirming procedures with important services such as HIV care or smoking cessation, that we may have a synergistic effect. And the patients will come in for their hormones, and then while they're there, you can talk to them about HIV prevention or HIV care, etc. Next slide, please. So very briefly, without getting into too much of what this means, there was a study that was recently published that found that for every quality-adjusted life year that you gain from providing gender-affirming care, you save $8,655. And this is rooted in the risks of unaffirmed gender with associated depression, suicide attempts, substance abuse, and those things are very costly. And so when we provide what are really moderate cost procedures, we actually can save the healthcare system money. Next slide, please. So the goals of feminizing hormones are to develop feminine secondary sex characteristics and to suppress masculine secondary sex characteristics. Next slide, please. So the feminizing effects of hormones are pretty straightforward. Development of breasts, fat redistribution, reduced muscle mass, reduced body and to a lesser extent facial hair, some arrest or reversal of scalp hair loss. There'll be changes in odor and perspiration patterns. Next slide. Some other effects. There are effects on libido and erectile function. Erectile function will decrease. And there's reduced or absent sperm count, and so infertility is something that should be discussed, and transgender people, transgender women should consider storing sperm before beginning hormone therapy. Conversely, it's not reliable enough of a contraception that you could say to them, oh, you can go have sex with someone who could get pregnant and you don't have to worry about an unplanned pregnancy, because that's not true either. So it's neither effective contraception, but it also places you at risk for sterility. So both of those discussions really should happen with trans people. And then there are a whole range of changes in emotional and social functioning that, without projecting stereotypes, people just may feel different. They may react differently in different situations. What exactly that looks like differs from person to person, but it is something that can sometimes be jarring or frightening to some people. Next slide. The general approach is using an estrogen plus a testosterone blocker or an androgen blocker, and then sometimes a progestogen is used. Next slide. So the side effects of estrogen, these are things that you might be familiar with from managing patients undergoing contraceptive management or menopausal hormone therapy. And we don't really have time to get into the details of how to manage these in detail, but just things to be mindful of. And when hormone therapy is managed properly, without excessive dosing, you can minimize these side effects. Next slide. Next one, please. Great. So the goals of therapy, masculinizing hormones, are basically the opposite of the goals of feminizing hormone therapy. Next slide, please. So I think we all are familiar with the masculinizing effects of hormones. And most interesting here would be the clitoral growth to be expected, deepening of the voice, and frontal and temporal hairline recession and male pattern baldness, and then some of these other changes as well. There will be, in many, an increased noted libido, though transgender women may have an increased libido as well, even with blocking of testosterone, because they may suddenly feel so much more comfortable with their body that they feel comfortable being sexual people. there may be some symptoms of vaginal dryness, and this can actually make it more difficult to obtain a Pap specimen. And then infertility, it's possible that trans men may not ovulate while taking masculinizing hormones, although it's possible that they may. So it's another one of these things where it can cause infertility, and we don't really have enough data to know if this can be permanent. Like if you stop testosterone, will you resume ovulation, or will you require medical fertility treatments to do so? At the same time, some trans men may continue to ovulate while taking T, placing them at risk for unplanned pregnancy. So we can go to the next slide. Great. So the approach is generally one of several forms of parenteral testosterone, parenteral meaning non-oral. There's currently no oral form of testosterone, and they only use skin preparations or injected preparations. Other adjuncts may be used in some cases, and don't really have time to get into why, but just wanted to put that on your radar. If we can go to the next slide. Last topic I want to talk about is transgender youth. This is a huge topic. Basically, there are benefits of identifying transgender people as children before their natal puberty, which allows the avoiding irreversible hormone changes, things like deepening the voice or skeletal structure, maybe not being as tall as they would have been, depending on their which direction they're going in. And they also, identifying trans youth early would gain the benefits of an age-appropriate felt gender transition, so they would go through their puberty at the same time as their peers without having ever undergone the wrong puberty, and there's a lot of benefits there. So the big questions right now are how to identify trans youth that are appropriate for medical interventions. Obviously, before puberty, there's really no difference between boys and girls on a physical level with respect to secondary sex characteristics. And so there can just be social adjustments. You know, you can live as a girl except when we go to visit grandma, or you can live as a boy next year when we move to a new town and start you in a new school. Once children reach a Tanner stage 2 of puberty, which is a landmark of puberty that has specific findings, and it's basically, you know, right on the verge of menstruation for girls, and right on the verge of facial hair development for boys, and that's just speaking about cisgender people. When trans youth have reached those Tanner stages, that is the time when either puberty blockers or hormones, depending on the social situation and how the support is going, would be indicated. So that's all we really have time to talk about on this, but I just wanted to put it on your radar. If you can go to the next slide. We do know that trans kids who transition have better mental health outcomes than those who do not, and that trans kids who transition basically have mental health outcomes similar to non-trans kids. So when you allow kids to transition, they basically develop the mental health profile of a non-transgender kid. So that's really important to know. Next slide, please. So the last slide will be talking about health outcomes relating to hormone therapy. Everything that is circled here in red, basically this is a retrospective study from the Netherlands that looked at mortality as an end outcome in a population of transgender men and women as compared to the national death rates for all of these cause-specific mortalities as well as overall mortality. Everything that I've circled in red is an area where there's increased mortality in the transgender population compared to the general population. If we look at trans men first, it's very easy. The only place where trans men had increased mortality, it was not cardiovascular, it was not stroke, it was not diabetes, it was only in drug use, and that is most likely related to the profound psychosocial stresses that transgender people experience. All-cause mortality was not different for transgender men. When you look at these, you have to not just look at the number, but you have to look at the confidence interval, and if the confidence interval crosses 1, then it is not statistically significant difference. With respect to transgender women, they did not control for smoking in this study. So we look at things like cancers, ischemic heart disease. I don't really know what to make of those because we know that transgender people are more likely to smoke than the general population. The other thing is that even if there is some increased mortality from hormone therapy in transgender women, I don't think there is. I think this is confounding. But even if there were, we have to look at the benefits of hormone therapy. So we always have to think risk-benefit. And so we have to say, well, maybe this mortality increases a little bit, but what is the mortality if they had not been treated? And again, as you can see here, most of the causes of mortality has to do with HIV and has to do with drug use or suicide, all of which more likely have to do with a lack of access to gender-affirming treatment and hormones than directly relating to the hormone therapy. So I believe that is the last slide in this presentation. And then there's a fairly lengthy bibliography that I've included here. So thank you.
All right, thank you. And we have one other question that came in. We heard earlier that family acceptance is a critical factor in quality of life for trans people. How can providers and staff help parents and caregivers with the transitions of a trans adolescent?
So the question is, how can parents help the providers?
How can providers and staff help parents or caregivers?
Yeah, so that's a great question. I think that the first thing that providers can do is allow the child to identify themselves and to listen to the child and let them tell the provider who they are. The provider at the same time needs to meet the parents where they are, including all of the guardians and stakeholders in custody of the child. So this could involve an out-of-state parent in a divorce situation. There could be involvement of the foster system. And what's required is to take an inventory of where everyone sits, take an inventory of the child's puberty staging, and come up with an action plan that takes into consideration all of those things. A great resource that every parent of a trans child should be familiar with is the organization Gender Spectrum, which is it's based in the Bay Area, but they are a national, and they have a number of resources for parents of trans youth, and they have an annual conference in the Bay Area as well, so that would be a good resource for them.
Thank you. All right. Well, thank you all for your participation, and a special thanks to our speakers. This final slide includes links to the UCSF Center of Excellence and to Lyon-Martin, as well as the online home of the California Improvement Network. Again, if you missed part 1 in this series, that's available on the CIN website, third link here. And the slides and recording of this session will be available on that site in about a week. Lastly, please look for a follow-up email with a link to a very brief survey. We'd appreciate your feedback on this session and also your ideas for future webinars or other California Improvement Network activities. Thank you again for your interest and have a good day.